Okay. All righty. So you listened to the lecture. Let's start with any questions that you may have in regards to what I talked about with community assessment, which is really what the first lecture is all about, is how we assess a community and the difference, with community nursing versus hospital-based nursing. So what kinds of questions does anybody have specifically? No? Okay. All right. Well, then what I'd like for you all to do is, one more person coming. I think this is, okay. What I would like each of you to do is to write in the chat what community nursing is to you. When you hear community-based nursing, community nurse, what comes to mind? And if you would just write that in the chat, please. So what is community-based nursing to you? What does it mean? Nursing, okay. I don't know how to make it private, but that's okay. Just write your own definition of what you think it is. Shiku, could you unmute your video, please? Thank you. And what I asked is for each of you to write your definition of what a community-based nurse is, or what does it mean to you to hear the words community nursing? I'm only seeing 2 responses so far. Good. Keep going. I used to be able to do this with Poll Everywhere, and it would show a really cool graph. But we'll use the chat and go from there. Can you guys see all the answers? Health promotion, helping in the public setting or in people's homes. Yep. Let's see. Nursing that focuses on the care of the community rather than just the individual, helping people in their homes or outside of a medical setting. Well, outside of a hospital setting, because community nursing is in medical settings such as clinics and all. So even break that down from medical setting to hospital setting. Nurses taking their knowledge and skills out to the public, promoting the best outcomes for patients. Good. Holistic medicine, nursing that not only encompasses the vitals, past medical history and current, but encompasses their homes, jobs, and environments that affect their health. Excellent. Caring for individuals and families outside of hospitals. Okay, it's taking care and putting back into the community as it can be applied to better the care of people, allows nurses to do more than is proactive instead of after illness. Okay. Nursing that focuses on public health, helping public and community gain health and wellness in the community where they live and work in the community for health promotion, disease prevention. Excellent, excellent, excellent. Health promotion and prevention, people in the community. Okay. Health fairs, yep, okay. All right. Okay, class is over, you guys got it. No, I'm just kidding. No, you did, that's exactly what it is. And as I talked about the history in the first lecture, you were able to see and hear me talk about how nurses really have been part of the community and caring for the community since the beginning of time, really. And it is a pendulum that swings back and forth from community to the hospital, but back to the community. But essentially, because so just patients in the hospital are really just your very, very sick patients that cannot be cared for in the home. Otherwise, our care is really in the community. How many of you are in any positions right now working in clinics or any kind of community-based nursing? Any of you? Okay. In classes in the past, I've had some students that work in home health, some that work in, like in urgent care centers or clinics. So there's a wide variety of settings and where different folks work. So I suspect that a percent of you will end up working in community-based nursing at some point in your careers. Just a little background about myself. So I initially worked as a med-surg nurse when I first graduated for 1 year, but I was an ER nurse for several years, and then ended up working as a home care nurse. And I stayed in home care and hospice in the home for over 25 years. At which point I did go back and get my master's degree 18 years after I graduated from nursing school. And then when I moved to Maryland 20 plus years ago, I worked in home care and then in education. And so my background is primarily public health. My master's is in public health nursing. And I am a very strong advocate for community-based nursing. There was a time when physicians, and this is another pendulum swinging back, where doctors used to see patients in their homes. And as a little girl, I used to go with my father, who was a general practitioner, whose birthday would be tomorrow at 114 if he were still alive. But as a young child, I used to go with my dad and he took care of people in the very poor neighborhoods in Philadelphia. So it was really, I think, my love of community and public health and caring for people in their homes began from the time I was very, very young. And it has carried throughout my life. We'll be able to see in this class examples of how using the COVID-19, this pandemic, and how we can apply the principles of what we're going to learn in community nursing. You'll see how, for instance, you'll see how that pandemic has such an effect, or excuse me, I'm trying to think of the best way to explain. Anyway, there'll be examples in all the things that we're going to talk about today that we can apply to what's happening right now and during the pandemic. We will talk much more specifically about infectious diseases in our second lecture. To begin with today, though, let's just talk about, so we know that community health nursing is out in the community in multiple settings, which we'll discuss in greater detail in our second lecture. But what the goal of a community-based nurse is that health promotion and health prevention. And I talked about the 3 levels of prevention. And so who wants to tell me can you explain the differences between the 3 levels of prevention? So what about primary prevention? Anybody give me examples of primary prevention?
Immunization.
Say that again.
You mean the blood vaccination?
Okay, so a vaccination would be primary prevention. Okay, what else?
Smoking cessation.
Say it again, Hazel.
Smoking cessation.
Okay, so teaching people not to smoke in the first place, right? Okay.
Hand washing.
Say it again.
Hand washing.
Hand washing, so preventing the spread of infection through hand washing, right? So, okay, so those are primarily, we're talking in primary prevention, preventing something from happening in the first place. And that's really the goal of what a community or a public health nurse focuses on is primary prevention. How do we know what areas to focus on? We'll talk about secondary and tertiary in a minute, but let's follow up on that. So a public health nurse is really focused on primary prevention. How does that public health nurse know what areas to focus on? How do they know?
They could do needs assessments in the community.
Exactly. So they're doing a needs assessment of the community. What's going on in that community? And so, and we'll talk further because I mentioned it also in the lecture about the different ways that we assess the community. Okay, so we assess that there is a great percent of the population that smokes cigarettes or uses other tobacco products, and there's a high incidence of cancer. So the public health nurse is looking at the data, looking at the information, doing the assessment, and then has to come up with the plan and ways to curtail, or in primary prevention, prevent people from stopping smoking in the first place. And we've been pretty successful with that one. And that started back in the 1970s with the initial Healthy People Initiative, was to decrease the amount of tobacco product use. And I know I brought all that up in the lecture, you know, where the campaigns where they stopped advertising on billboards and in magazines and on television and everywhere else, you saw all the time the glorification of cigarette smoking. They started programs in schools, because if you start preventive programs and get kids in grade school, you'll have the hope is for a better success, that the kids won't ever start smoking. Okay. So those are some primary, and our goal is always to try and do preventive primary prevention, because if we can prevent the disease from happening in the first place, we're going to save a lot of money in terms of health care costs, and people will live better lives, better, healthier lives, right? So we want primary prevention. But what's the next level? It's secondary prevention. So I'm sorry, go ahead.
Screenings.
Screenings, absolutely. So what kind of screenings are we doing as nurses?
Mammogram?
Mammograms. So are we doing the mammograms?
No.
No. So what do you mean by that?
Educating clients?
Educating your patients, your clients in the community of the importance of getting an annual mammogram. Okay, so that's great. What other examples? Say it again.
Blood pressure
screenings. Yes. So we do blood pressure screenings all the time, right? We do them at health fairs. Nurses mostly in community settings like health fairs, they'll have blood pressure screenings. Yeah. What about a school nurse? What kind of screenings do they do?
They screen for lice, they screen for scoliosis in children and BMI, I think.
Okay. All right. So looking at weight. Okay. So let's use the example of in the community, there is a high incidence of obesity in a community. So the school nurse could be part of, so for instance, in Carroll County, there's a partnership for a healthier Carroll County, and that's where I live. So I used to be on this partnership with the health department. And it was a group of concerned citizens from all different aspects of the community that came together to address looking at the healthy people indicators, but to address, in this instance, it was obesity. And it involved the school nurses and setting up programs for teaching about better nutrition, exercise. But it began first with screening to see what was, so one of you mentioned BMI. Yeah, looking at the BMI of these kids. So those school nurses are doing heights and weights, and then they're able to determine the BMI and then the incidence of obesity. So they collect that data, and then, you know, through these campaigns, continue to evaluate and reassess and to see how they're doing and what they might need to do to make it, you know, to continue to improve the outcome. What does that sound like to you guys? What are they using? You learned it in fundamentals. When you're assessing, you
The
assess.
nursing process.
Exactly. The nursing process is used in community assessment, just like it is when you're caring for patients in the hospital. Okay. So you're going to assess the community. You identify the problem. You have to collect the data, the information, then you plan, right? Set goals, interventions. What are we going to do to improve this situation? Comes after goals and interventions,
Evaluation.
right? But before that, what do you have to do? Implement, right?
Implement.
Right. Implement, then evaluate, reevaluate, and reassess and redo goals if necessary. Okay. So your secondary prevention, the problem has already occurred. You know, or the person may already have high blood pressure, but we're doing screenings that maybe we can identify that blood pressure as being elevated and get them the education to take the steps to hopefully lower the blood pressure through diet and exercise and or medication. Okay, so it's so different screenings to help to begin to reduce the incidence of that problem. Tertiary, what happens in tertiary prevention? What's going on there?
Treatments?
Treatments? What do you mean by treatments?
Because if a person is already sick, you want to do things to help the symptoms of the disease that they have.
Okay. And by doing that, what are we doing?
Preventing the progression of the disease.
Preventing the progression of the disease. Mm-hmm. And
Improving their quality of life.
Exactly. That's what I was just going to say. So that's exactly right. So we're improving
Sorry.
the quality of life. No, thank you. No, I need to learn to listen more, which is the art of nursing, right? Listening, part of that communication piece. But yes, so it's maximizing the quality of life for that person who already has the chronic disease. So the wellness illness continuum, can somebody with chronic disease be at the upper end of the wellness continuum? You're shaking your head, Ophelia. Tell me why.
Because if they're able to like have chronic disease and still do all the things they're supposed to do, they can essentially be at the like healthiest part even with that disease.
Exactly. So even though somebody has a chronic disease, that does not put them at the low end of the wellness illness continuum at the illness end, if they're living at the best possible point in their life with that chronic disease. Okay, so so doesn't mean people that have chronic diseases are always at the low end or the illness end. Yes, they do have an illness. Yes, they do have a chronic disease, but we can maximize the quality of their life. Okay, so chronic diseases account for a lot of the care that is provided in the community, particularly because nurses in community do see patients in their home. And while you can be of any age to receive home care services, as long as you meet criteria, a good percent of the people who do receive home care services, and we're going to talk at length about home care, so we'll get into all this in detail on the third lecture. But those that do receive home care services typically have chronic diseases. They tend to be older adults, and Medicare, usually they're already on Medicare, but not necessarily. There are lots of elderly people or older adults who don't take any medicine, do not have chronic diseases. So just because you get old, and I am past Medicare eligibility at this point, which is partly why I retired. But I will tell you, when I go to the doctors and they ask me what medicines I take and I say none, they're like, none? Like, I mean, it's like people expect that once you reach a certain age that you should start being on medicine. No, not necessarily. So what's the key? Stay healthy. Practice primary prevention. Make sure you take advantage of healthy foods, green spaces where you can go out and walk. You know, during the pandemic, gyms shut down, but a lot of people but people took up walking and, you know, being in the outdoors and getting out of their home and walking and you know, improve. So whatever you can do to stay healthy and live a healthy life, it's important. So to prevent chronic diseases from happening in the first place. And really, so that's the goal, that's what health promotion is all about, is promoting healthy behaviors. Okay. So those are the 3 levels of prevention. So with the chronic disease, the tertiary prevention really is focusing on people with chronic disease and how to live within the state of their own health as it already exists. So, you know, how to manage the symptoms, how to recognize, like a CHF patient, how to recognize that they might be going into cardiac heart failure because their weight gain or they're starting to feel more short of breath. So we teach them how to manage that congestive heart failure and be alert and daily weights and fluid restriction, et cetera, so that it doesn't become an exacerbation or end them where they end up back in the hospital. So, so those are the 3 levels of prevention that community-based nurses, and frankly, even nurses who work in the hospital need to be aware of, because what's such a large portion of what we do as nurses is educate, right? We educate our patients how to manage their medicines, how to manage their diabetes, whatever their disease is, whatever it is, we're teaching, and that occurs also in the hospital. But again, we're going to focus, this is all about community-based nursing. Okay, so when we're assessing, there were 3 terms that were used, social determinants of health. Can anybody speak to what are the social determinants of health?
Your zip code?
Oh, your zip code? Okay, well, what does that mean, your zip code?
Where you live?
No, right, but so where you live could determine your health, is a social determinant of your health, is what you're meaning, Bridget?
Yeah, if you live like in the inner city, you might have a lot more automobile pollution or lead paint in your row homes.
Mm-hmm, mm-hmm, absolutely, yep, so that is the social determinant. Okay, what else, what other definitions can you give me for that?
Your age?
Okay, all right. Why would age be a social determinant of health?
I guess if you're dealing with someone who is later in years and they live in a community where there's several that are later in years, you would gear your prevention or your promotion towards them.
Okay, okay. So someone in later years, their social determinant is that they may be more frail, or there's a greater chance of falls and things like that. So that may determine some of their health. Okay, all right. I'm looking for something here. What else? What are some other?
Your socioeconomic status.
Exactly. And what about that? Why is that a social determinant of health?
If you're in a lower economic status, you have less access to like health insurance and
Mhm,
healthcare. You might not have transportation available to you.
mhm. Okay, absolutely. What about a person's biology or genetics? Do you think that's a social determinant of health?
Yes.
Yes. Why do you say, Harry?
I mean, they're pre-exposed to certain health conditions, and yeah, they're pre-exposed to certain conditions.
Yep. So certain races have a higher incidence of even hypertension or higher risk for certain diseases. African Americans or people of Mediterranean have a higher incidence of, oh my gosh,
Sickle cell anemia.
sickle cell anemia. Exactly. Yeah. Thank you. It was escaping me there, but yeah. So there are certain populations of peoples that have a higher incidence of certain diseases. Some of it is caused by genetics, but some of it is also environmental. There may be a higher incidence of among people. Well, so I just heard it again this morning, you know, with COVID-19, the incidence of people that have gotten COVID-19 and or gotten really sick and died from COVID-19, it is disproportionately happening more so in populations of people of color. And some of the reasons are because they have a higher incidence of chronic diseases. And there's a whole lot of reasons why that happens, which I think, you know, some of what we've already talked about indicates that. But it's you know, so it's access to care also. So what is the so the social determinants? What about some of the healthcare disparities? What would be some healthcare disparities? Hmm?
Discrimination.
Okay, all right. So the disparity is discrimination, but what is another way of saying that?
Gaps.
Hmm?
Gaps.
Gaps. Okay, so someone who lives in the inner city may live in an area where there isn't a lot of green space, so they can't get out and get that exercise. That's a disparity right there. Where you live. Go ahead, Antoinette.
Sorry, food deserts in
Food deserts.
urban areas.
Absolutely, yeah.
And overpopulation as well. I think in places that are overpopulated, there's less healthcare professionals to treat at all the clients that they need to see. So they're almost not being as vigilant, just trying to treat everybody.
Okay, all right. Could be overpopulation or underpopulation. So think about rural areas, people that live out in very rural areas where the nearest health center is 100+ miles away. You know, so their access to care, they don't have clinics available that they can go to, urgent care centers that are close by, because they don't have the healthcare providers in those areas. So the access to care. So geography again can be a disparity. Okay, so being aware of all of these factors goes into the health of the population. And so we have, and we're going to look at healthy people, and we're going to do I'm going to put you guys in little breakout rooms, and we're going to do an activity in a little bit. But in Healthy People 2020, so they have the leading health indicators. So what would be a leading health, what would be an indicator, a health indicator? Maybe looking at access to care as a health indicator. Or another one is the rate of obesity in an area. That they use that, the mortality, morbidity of infant mortality is used as a health indicator. So these are indicators, these are points that are looked at, and then look at the population and see how they reach those indicators or not, and what's going on and why, what is the gap, what is the disparity that's preventing them. So they pick these overarching indicators to determine the health of the population. And that's what's used by researchers and used with the Healthy People 2020 that they review every 10 years and develop new indicators or continue with the same one if the outcomes have not been met. Okay. So we talk about vulnerable populations. What does that mean when we talk about vulnerable populations?
People that can't necessarily look out for themselves, like the elderly or children.
Okay. So they can't necessarily look out for themselves, provide their own care, maybe? Is that what you're thinking? What else would a vulnerable, who else? So again, think about COVID-19. I'm sure you guys have heard some of the news. It's kind of everywhere. You can't miss it. But access to vaccines. What's happening there? Who are the vulnerable populations? They're the ones that may not be able to get those vaccines as easily. What would be some of the reasons?
People without transportation.
Right, people without transportation.
Language barriers.
Language barriers, yep.
Lack of access to technology. I know a lot of the scheduling is online.
Absolutely, that has been a huge problem. What other indicators there?
Maybe lack of education as well, as far as like how effective these vaccines are and what the side effects may mean. As a lot of people see like the side effects as bad, but they could mean that the vaccination is working. Like you're just having a strong immune reaction instead of this is a side effect that should be watched.
Absolutely, yes, yep. So getting folks, vulnerable populations are those groups of people who cannot get to the vaccination sites. So a community outreach worker is going to go into the community. There are mobile vans that are reaching some of these communities that are very vulnerable because, as someone mentioned, there is no transportation. Another possibility is they don't have the correct ID. You know, they because they don't drive, they don't have a license, so it's that whole ID thing too. But there are now, and you'll see in the next lecture, I put some videos up. There's one that was from CBS Sunday Morning, which is the Sunday morning news program, and they did a video, which I posted the link for you guys to watch because it's all about Baltimore, which is pretty neat, and the initiative that with Johns Hopkins and the outreach into the community to reach people for not only vaccinating, but also testing and educating. As you said, Christine, we have to educate because people don't, there's a lot of fear that goes around the idea of a vaccination, particularly in populations of color, because there have been times where there have been experiments done on, you guys ever heard of the Tuskegee experiments, which was with the venereal disease and syphilis among Black men. And there was a lot of truth to why they may be afraid of getting that vaccination, but because of history. But we have to educate so that people realize that that is history and we learn from history, but that's not what this is about. So education is very, very important. Very good. Yeah.
What about children of like anti-vaxxers? Like you have the anti-vax community, you know, people that don't believe in vaccines to begin with, and then their children, you know, maybe they really don't have control over because, you know, they have to do what their parents say until they get old enough. So that's also another population, I guess, too, that would be vulnerable.
Absolutely. Absolutely. Good point. Yep. They would definitely be vulnerable. I've even heard conversation around, not so much about the COVID vaccine, but just in general. At what point does that almost border on child neglect or abuse? Because your child now is going to be vulnerable and susceptible to diseases that are absolutely curable. You know, we don't have polio anymore. When I was a kid growing up, that was a big fear, was polio, you know, and it was through educational campaigns. The same with smallpox. We eradicated smallpox. We eradicated measles. And a lot of diseases no longer exist, or they only happen in areas where people are not vaccinated. So yeah, you're absolutely right. That would be kids then that are considered very vulnerable to getting a disease that is normally very preventable. Good point. So it's important that we look at you know, these social determinants of health, the health indicators and the disparities, so that we can address them, and as nurses educate and advocate. So advocacy is a huge piece of what a nurse is involved with in community nursing, is advocating for all people to have access to care, all people, you know, and I mean, it sounds so easy, but it's not. I mean, it does take grassroots efforts. You need the data, the education to show why something needs to move and show improvement in the health of a population. So very, very important to be aware of these different indicators. And again, we're going to have time. We'll do this Healthy People's activity. So Do you guys understand the difference? And again, I said in the lecture, and I'll reemphasize, you don't need to worry so much about community-based nurse versus a community health nurse. They are used interchangeably oftentimes. The public health nurse typically is at a BSN level or higher. And even a nurse, though, nowadays in home health, they want nurses that have bachelor's, minimum of a bachelor's degree. I don't think they would say no to a nurse with an associate's degree who wanted to be a home care nurse, because they have really good orientation programs now in home health. But the actual public health nurse is a nurse who works usually at the county health departments or state. You know, every county in a state has their own health department. So those nurses, and they focus primarily on primary prevention. Okay, so they're collecting all that information, the data, they're coming up with policies and working to overall improve the health of a population. Whereas a community-based nurse, which is really what our focus is for this course or these lectures, is the nurse who works in community settings. And there are various settings, which we'll focus on the second lecture. But a big portion of the community-based nurse is in home care. And those are typically patients with chronic diseases. So their focus is more on tertiary prevention and some secondary. Whereas the public health nurse is really focused much more on primary nursing, primary prevention. Okay. No matter which area it is, it's all about education and health promotion, health wellness. Okay. So the themes here are pretty consistent across all, you know, whether you are a public health nurse or a community-based nurse. It is really about health promotion and disease prevention and wellness and teaching wellness. And that includes, as someone mentioned, that there are food deserts. So we want to teach about healthy nutrition and access to healthy foods. There are community groups that have community gardens in urban areas, you know, so there are so many grassroots community efforts. Some of them have nothing to do with healthcare. They're just community activists who want a healthier and better community for where they live, or, you know, their family lives, whoever. But, you know, there's a whole lot going on out there in the community. And it's really in all of our best interest to ensure that we live our healthiest life as well. So let's talk for a minute. There was a video on upstream thinking, and I talked a little bit about that in the lecture portion. So give me your interpretation, what you think of when you hear upstream thinking, and maybe give me an example. Anybody? What's upstream thinking? Any thoughts on that?
It's more about the prevention of things.
Mm-hmm. So it's primary, isn't it? It's primary prevention. It's really getting to something before it becomes a problem. So addressing it. So in the video, what happened in that video? What was it that in the TED Talk that he what was the story there?
He talked about the one friend started swimming upstream rather than saving the children at the point where they jumped in or right before they fell over the fall.
Okay.
And that person was going to find the primary location and stop the kids before they ever got in the water.
Okay. So it was a lady he talked about who had those chronic headaches, right?
Mm-hmm. Veronica. He said that she went to several different doctors and none of them could really address the problem until she came to him, and they asked her where she lived, and whether there was mold in her home, whether there was roaches and something else. And he was able to see just by like the line on her nose that she had allergies, and it had to do with where she lived. And by addressing those 3 issues, they were able to address the allergies and prevent the migraines and her child's asthma from getting worse.
Mhm. Exactly what was happening is, to this woman, she kept going from doctor to doctor, and all they wanted to do was treat the symptoms. If that's all we're about is treating symptoms, we're never going to get to the root, the cause of what's happening. And by finding the root cause of something, we're able to hopefully, fingers crossed, eliminate what it is. So in the case of this video, he talked about the woman with these chronic headaches, and then was able to really dissect what was happening and evaluate what was her home environment, so that that could be addressed, and then her headaches were gone because they were able to address the environmental quality of her home. There are actually organizations and groups, and I wrote it down, I don't know which one, but there are, it's called the Green and Healthy Homes Initiative. So that's just one group that will actually go in and they can do things, they can clean your home to the point where to eliminate the mold or the lead paint or whatever it is. So their environmental health is key. So when we're doing our assessments, we want to ask those questions. We don't want to just, okay, focus on the disease and the symptom and treat the symptom. We need to try and find the cause. So upstream thinking is really, again, primary prevention, stopping something before it happens in the first place, or if it's happened, at least stop it from continuing by addressing the cause of it, okay? Downstream thinking is more traditional medicine. That's primarily how most physicians treat patients. Is you come in, the patient comes in, they have a problem, well, here's a pill for that. Or they might order some diagnostic tests depending, but that's downstream thinking. That's not being proactive. And upstream thinking is being proactive and really trying to get to what the issue is to stop it from getting worse or from ever happening in the first place. Okay, so you think about examples that you can think of with your own patients that you've already taken care of. And when you do assessments or your own family, just think about some of those things and how you would meet it head on in an upstream thinking way, as opposed to after the fact and downstream, right? So you need to understand the difference between them. And a lot of this, so let me just say here about community nursing. This is very new for you guys in terms of learning community nursing. It's different than learning a disease, like you all just finished GI. So you learn specific diseases related to problems with your GI system. And you were able to memorize a lot of things in order to be successful in your exam. Community nursing is really starting almost like a fundamental students, because you're learning, this is very new. It's not necessarily disease oriented, right? So community nursing is more application than memorizing. All right, so understanding in a much more general way what we're talking about. And so that's why I want you to ask questions for application if you're not sure about something. But you're not going to be able to go to a book and just memorize to pass the test. It's really, you need to fully understand the whole idea of what it's about. And so that hopefully that's, I'm able to help you guys to think through some of these areas. as stated in Blackboard, you don't have a book for community nursing except for the ATI book. There are some practice exams on ATI. Some of the material that with those questions on the ATI, we won't get to. Public health or community nursing is usually a full semester course. Those of you that are in ATB programs will, if you haven't already, take a full semester of community nursing. But in our program, we're really just touching on the highlights of community nursing and giving you the opportunity through these 12 hours of lecture, how to apply in different areas of nursing. So, so not all those questions on ATI, you won't be able to answer all of them because we just don't have time to go through every single piece of that, which is much more, it's covered much more so in a full semester course. What else did I want to tell you? I will post on Blackboard a list of all the areas that you do need to be familiar with in community nursing. So that'll be on Blackboard for you. I'll post as many activities and different things that will help you with studying. Like there's a crossword puzzle. There's another one called living room language. You know, we and I'm sure you guys have heard this, you know, when you talk with patients, you want to use words that they understand. So living room language is, you know, rather than using medical terms, using terms that are understandable for the general population. So that's on there. So anyway, I just want to, it just came to me as we were talking, and I wanted to point that out for you guys in terms of your study. Your readings are through your Med-Surg book, and there's some others that there's some articles that I posted that are also going to be helpful for you guys. Okay. Okay, so what we're going to talk about now is how do we assess the community? Okay, so we've talked about the different types of, you know, vulnerable populations and social determinants and health indicators. But to get to all that, we start with a community assessment. So what are some of the community assessment modalities that can be used? How do we assess communities? What are some of the ways? Formats.
Is it the windshield survey?
Windshield survey. Okay, so we're going to talk at length about the windshield survey. That is probably one of the more common. Windshield survey is probably what is used a little bit more because it involves you're in the car, you're driving, you're looking through your windshield, and you're observing the community as you drive. You could also walk in the community and do the same observation. They just use the word windshield because the analogy with driving in the car. So we will talk a lot about windshield survey in a few minutes. What about key informants? What is that all about? What's a key informant observation or assessment? Okay. So with key informants, it's exactly what it sounds like, right? You want to know what's going on in a community. Who do you want to talk to? Who would you talk to if you needed to find out information about a community? Who would be your go-to people?
People in the community that are going to the community centers.
Okay, so like who would that be?
Some of your patients.
Okay, all right, but we're talking about key, if you are looking at something very specific, patient related, and you wanted to see how they felt about it or what their thoughts were, if they saw it as a problem or not, possibly, yep.
Did you go to like healthcare providers for the community or, I don't know, maybe ambulance, firefighter, police?
Yeah, yeah. So your police, your firefighters, the EMTs even, they would be key informants. They know what's, particularly the police will know what's going on in that community. Who else is a key informant in a community?
School nurse?
A school nurse would absolutely be a key informant.
Government officials?
Government officials. So your politicians, could be the mayor, could be, whoever the local political leaders are in that community. They would be key informants. They can tell you what's happening in that community. Okay, so those are your key informants. I have an example that I want to go through with you guys on a community assessment with a school nurse, but okay, here it is. So, but besides the key informants, what other assessments are there? The other one might be, the key informant's going to tell you what are the strengths, what are the weaknesses of that community. Might be the business leaders in that community, okay?
Focal groups.
Vocal groups?
Focal groups.
Vocal, right. So there may be just a community forum that's going on that you could attend and just be a participant observer of what's being discussed at that community meeting. Okay, so communities oftentimes will have, it may have to do with, building new homes on a 200-acre farm that just sold. So they may have a community forum where people talk about the pros and the cons about another housing development in the area. Or it may, for instance, right here in Carroll County, there was a big discussion about Piney Run Park, which is this beautiful park that they wanted to, the commissioners were talking about draining the lake and rebuilding the whole dam because there is a problem with the waterway. The community was outraged and came up with a new solution. So, the participant observer in this case would be someone who really just wants to hear what the community has to say and listens. So that would be another type of community assessment. The good news is they're not draining the lake. It was overwhelming to fix the dam without draining the lake because it would have destroyed a lot of ecology in the area, et cetera, et cetera. So good news there. So there is power in numbers and coming together as groups to focus on areas of concern. Okay, so the community assessments, let me give you an example of a school nurse. So a school nurse basically does assessments of the school community, what's going on. That school nurse might be seeing a high percentage of students that are pregnant without prenatal care. The nearest prenatal clinic is 45 minutes away. So these students, these high school students are presenting to the nurse without ever having had any prenatal care. So the informant interview is that the nurse is going to talk to the public health nurse in the area, the school principal, counselors. Those would be the key informants to talk about this situation of a high incidence of pregnancy among high school students and no access to prenatal care. Participant observations, that the students are actually, coming to the nurse about asking questions about sexuality or they're pregnant. The school board is consulted. The nurse is suggesting maybe adding a curriculum to the curriculum, some sex education. So they bring it to the school board and school board thinks about it, but the school superintendent is against it. So they have to collect the data to show why this would be helpful, why this would be important. They would identify the community health need, which is that the students don't have access to sexuality curriculum or, to prenatal care. So ultimately, it is agreed upon, because the nurse was able to collect the data, gather all the information through those observations and informant interviews, and then present that to the board, to the school superintendent. They were able to add that to the curriculum, and then it has to be reevaluated every year. So that's just like a really small example, but going back to the board after the 1 year and saying, okay, these are my numbers. This is where we were. This is where we are now, and show whether it's improvement or not improved. And then make changes as needed. So again, use of the nursing process, and it starts with that community assessment. So that's just one very small example. And I think if you guys think about it, you might be able to come up with some on your own as well. Okay, so community assessment. So let's go back to windshield survey. When we do a windshield, does anybody have any questions about any of that? Okay. With the windshield survey, do you know the areas that we're assessing, that we're looking at specifically? So I don't know, I think it's opened. Hold on one second. The windshield survey. Did I open that yet? If not, I'm going to open it for you guys today. Yeah, I'll open it today. So there's a windshield survey. Let me go back to the class. Ooh, where are you? There you are. I'm waiting for Dr. Eck Elliott to send me your groups. I believe you guys are 3 clinical groups, is that right? Okay. So we'll have 3 groups based on your clinical group. So, and today when we do this activity, I'm going to put you in your clinical group. So even though I didn't get the information, I will get it today with you guys. You'll give me the information. So we'll make that work. With your group, you're each individually going to do a windshield survey. You're going to look at there are 3 specific headings with 5 pieces under it. So the first heading is people. So when you do your windshield survey, you're going to drive through the community, and your group will decide your community. Are you guys all at St. Joe's? Is everybody at St. Joe's for clinical?
Yes.
Okay. So we wanted, last semester, we thought it would be good if you each did your community assessment near your clinical, because you could do it on a day that you have clinical. But your group can decide what neighborhood, but it has to be a neighborhood that each of you individually will do your own assessment, then come together and put together a small presentation, which we'll do on the 4th class. Okay. So you're going to look at the people in that community. Who are the people? Are they, is it a community of mixed color? Is it a community of more old people than young? Who are the people in that community? So on the windshield survey, you'll have a copy of this that I'll open up for you. As soon as class is over, I'll open it up for you. So for people, who are the people? Are they more women? Are they men? How are they dressed? Are they dressed appropriately? Ethnicity, is the residents racially divided, or people all live together? What about animals or pets in the area? There's a question about classes of people and any evidence of alcoholism, drug abuse, communicable diseases or mental illness, and how did you come to that conclusion? So there's 5 elements under people that you assess. The next one is places. So where is this community? So I want you to describe, where is the community? What are the boundaries? Are they natural boundaries? Are they man-made boundaries, political boundaries? Okay, so where is it located? What are the boundaries? If there are major health institutions in the area, where are they located? And any evidence of other healthcare providers in the community. So again, we're looking at access to care. All right. What is the quality of the housing? When were the homes built? Does that give you any food for thought or pause to think about, okay, these homes were built before a certain, like in the 50s or 60s, what might be a problem with those homes? So are they in good condition? Are they in disrepair? Are there boarded up abandoned homes in the area? So all of those considerations, and then also industries, because we want to know about our neighborhoods. If they have a lot of industry, then there might be air pollution, right? Higher air pollution. And then third category is social systems. So when you do a windshield survey, you're also looking at the social systems. What kind of police and fire support? What kind of churches? How many churches? How about schools? Do the schools look like they're in good condition? How many schools? What type of social agencies are clinics, hospitals, dentists, grocery stores? Are there large grocery stores or only corner grocery stores? And then, parks, how much green space is in the neighborhood you're assessing? And then lastly, what about the roads, the condition of the roads, access to transportation? So by assessing each of those 3 categories and addressing each element under each category, you will get a really good idea of what your community assessment, what your community looks like, what areas you might have identified that might need some intervention, a public health nurse intervention. And how would you address those? How would you address that? So all that information will be posted as soon as we're done class. I'll open that and you'll see it. So you guys will work together in your groups to put together your presentation. When each of you do your assessments, this way you can compare and contrast with each other in your group about that specific neighborhood and see what, it'll help you to really focus on, did you all notice this one thing, or did only one of you, or, whatever it is. So comparing and contrasting what each of you are observing in your community windshield assessment. And then again, that'll be a presentation at the end during our final class. And then there's also a place for you to upload your assessments. Okay, this counts as a quiz grade. The windshield assessment is a quiz grade. That's the only outside of the exam grade for this portion of the course for concepts 2. All right. Any questions about that?
I have a question about the assessment.
Okay.
So are we able, so basically for the windshield assessment, are we only documenting what we see? Or like if something's near the hospital, we know that hospital's there, but if you can't, you know what I mean? Like, do you only document things that you can see when you're, like, say you're driving through the neighborhood or something like that? Or can you go by knowledge? You know what I mean?
Mm-hmm. Well, I prefer that you see this. So, you may end up in a neighborhood that you live in, but if possible, try to pick a neighborhood that would be different or new to you. It could be, St. Joe's, I'm sure there's multiple neighborhoods in the area that you could assess. Now, each group, I've never had where people end up doing the same neighborhood. But we've only done the groups doing the assessment and the presentations this spring. We, in the past, have only ever had everybody just do their own thing and hand it in. I think there's more learning and value in working together and, you know, again, doing some comparing and contrasting. So if you're in a neighborhood, not every health institution is going to be right there. So it is observation, but it's also, you can get information from the Office of Vital Statistics. So you do need to have some evidence for why you're putting what you do. Okay, so there is, well, here, let me see if I can, I don't know if I can pull it up by doing this or not. Probably not. Let's see. Nah. All right. I thought maybe I could. But you guys give me 1 second. I'll open it up for you because it's right here. It'll take me 1 minute to do it. And then this might help you to see. Okay, open it up. Oh. Okay. All right. All right, so I just opened it up. So anyway, so if you have questions, you do have a little bit of time to work on that. So it's in Blackboard. Okay. Oops. So the last portion of today from the lecture has to do with the family assessment and the importance of including family when we are working with or caring for patients in the community. It involves including our family, right? So, so the 15-minute interview. Can anybody speak to me about the 15-minute interview and what were the key points about that? Why do we want no more than 15 minutes? Did you guys get a chance to look at that 15-minute interview? What happens if you talk to people and you go on and you schedule, who's got time for more than 15 minutes? Anybody? We barely have time sometimes for 15 minutes to meet, but that's the maximum amount of time that you want to spend on any kind of an interview with a patient and or family. It's a good idea to include the family in that interview. What do you need to think about when you are doing family or doing a 15-minute interview and you're including the family? Can it be any family member?
I guess the direct family that's living there in the house at that time, instead of like people that are just visiting, because it directly affects them and like where they're playing, how they're communicating with the family, and how they're interacting in the home.
Okay. All right. Is it every single person living in that home? What do we need to think about?
You need to get permission from the patient in order to talk to them.
Exactly. We have to make sure we honor the HIPAA requirement. We can't just randomly start including family members or talking to people unless that patient has given the okay for this family member to be involved in that conversation, in that teaching, in whatever interactions that are taking place. But you're absolutely right, Christine. It is all about who are the family members that are living there and what is their involvement going to include, right? What else do we, so we know we want to include our family in our teaching, in our interaction. So in the 15-minute interview, there were 5 elements. Do you remember what those elements are? What's important? first thing when you want to even just talk to a patient, but what's the very first thing you ever want to do when you're meeting with the patient and family?
Introduce yourself and tell them who you are and what you're doing.
Absolutely. And what does that do?
It just provides like less stress to the patient, and is not, it doesn't seem like it's coming off as like very invasive. Like if I come into a patient's room and I'm just going to go check their IV and not tell them what I'm doing, they're going to be worried, they're going to be frustrated, and yeah, so.
Absolutely.
It
So
starts a
establish-
relationship with them.
Go ahead. What, Bridget?
It starts your relationship with them. So you're like building a rapport.
Exactly. Yeah. You're building trust, you're building rapport and respect. That's being respectful, right? Let them know who you are, what you're doing. Don't assume that you can just call them by their first name or their last name. You always want to ask, what name would you like to be called by? Okay. The other consideration is cultural consideration. In some cultures, it's not, you really have to know what is okay in that culture in terms of meeting with patients and families as well, okay? So keeping in mind the cultural component as well is very important. Okay, so the first thing we're going to do is we're going to establish trust and rapport by introducing ourselves. Excellent. What else is important in that interview?
Observing your surroundings and their facial expressions.
Okay, and what does that do?
Like when you're asking questions, you can see how it affects them, whether they're genuine, and also as they're speaking about their environment, you can look around and see just how much that affects their health or affects them, that sort of thing.
Okay.
It's a bigger picture.
Yep. Okay. That goes a long way in just observing the interaction between those family members. You may sense right away that they have a great rapport, total mutual respect for each other, or there may be a lot of tension that you can pick up on. And if you notice those things, it helps you in kind of having an idea how well this is going to go or not go. You know, I'm sure you guys have already had experiences in the hospital with patients and families. And how can families sometimes be? Nakia, you were shaking your head.
Overbearing. They can be overbearing. I don't know, intrusive.
They
needy.
can. Yes, indeed. But can we disregard them? No, we have to figure out what is that relationship. So that we get a sense of that relationship, and you may be able to even just asking some therapeutic therapeutic questioning will be some ideas about. Well, let's start with therapeutic conversation. So when we're using therapeutic conversation, that sounds so important. What does that mean though?
Really taking the time to listen.
Listen. Yep.
Eye contact.
Eye contact. Yep. Listening is very important.
You want to allow them to speak and open-ended, tell you what they want to tell you.
Good. Okay. Also letting them know that there's a time limit to this. You know, there's some information. Hi, my name is, and you know, introducing yourself, establishing that rapport, and and then letting them know the purpose of why you're coming to talk with them, and that it will be time limited, so that they don't think that you're going to be there going on and on and on. So being very direct as far as that, being therapeutic listening. Listening is so important. Purposeful. What is some of the information that's very important that you need to gather for patients going home in terms of care and that family situation? What questions are important to ask about?
The
If
home
they
they
have
live
support
in,
system.
Okay, wait, Nakia, go ahead.
kind of home they live in, and like who's going to be home with them.
Okay, so who else was talking there?
Sorry, that was me. I just said if they have a support system.
Okay, so who is their support system?
If they have all the medical supplies they'll need once they're discharged or access to them.
Okay. So, yep, and a lot of that will come under care coordination and discharge planning, and we'll talk a lot about that in the third lecture. So yes, those are all very important questions, but you want to know, who do you live with? Who is in the home and what are their ages? And what are their ages be important?
In case the client may be responsible for taking care of others, or codependent situation if they're elderly and they live with their spouse, and perhaps they need even more help than if they had, say, a daughter that was there caring for them, or a son, or
Yeah. So the age of the people in the house is really going to determine what other supports they may need, or that because they may end up being the one trying to care for those younger kids in the house too. So what are the ages is very important, just to get an idea of the relationships of the family members that are in that home. So what they call a genogram can also be done, but what is the health status? So you might have 3 generations of family members in that home. But are they home all day? What is their occupation? Are they working full time out of the home? Are they in school full time? So all those questions, again, gives you an idea of what the support will be in the home itself, if the people who live in that house are out and about and not really available to help. So that's why you need to get that, the ages, the occupations, their health status, because if they're sick, are you caring for them? And you're the one who's the patient, so what is their health status as well? So another key ingredient in a 15-minute interview would be therapeutic questioning. So what would be some examples maybe of a therapeutic question?
Open-ended questions.
Okay, so like for instance?
Instead of giving them like a yes or no option to the question, you want to leave it open. So instead of saying, do you take care of your mother? You could ask, what kind of things do you do to support your mother, or something, so it's not just yes or no based questions.
Okay, all right. You can ask specifically what it is that they need or they want. Okay. How are you going to know unless you ask? So being very clear about, what is it, what are your goals? What is it that you want or need from this relationship? Okay, so asking those kinds of questions. Asking them how they feel we, the nurse, can help them. What do you see that we can do to help you? What do you see as your greatest challenge? So asking those kinds of questions will help you to focus in on what it is that you need to, how to develop your care plan, essentially, which is really what you will be doing when you have these conversations. And then you begin teaching, you have to have goals in mind, and you work through those goals with the patient and the family. And then finally, the 5th element or key ingredient in a therapeutic 15-minute interview is commendations, offering commendation. So do you know what that means when you offer commendation?
I guess like in the TED Talk, he offered things that can be done further, like help with the public health lawyer and the health department to get further resources.
Okay. Okay. But that's good. In the context of a family interview, the commendations would be, what are the family strengths? So,
Yes.
so not saying, oh, you're doing a great job, because that's kind of like, well, you can say that about anything, right? But to be more specific, you do, when you're taking your mother, I see how well you're able to make sure her balance is good before she stands up, that you actually offer specifics, identifying strengths and caring for that person. Okay, so it's just basically not just, oh, you're doing a great job, but specifically, what are they doing that is such a great job? Because if people feel like they're doing a really good job, they're going to empower them to continue to want to do a good job, and not just with these little placates, oh, you're doing a great job. Yeah, let's talk about that a little bit more. Okay, so being more specific. So those are the whole idea of the 15-minute interview is really to help you as you are planning the care for this individual within the context of the family. Think about your own families and think about, how are the relationships in your own personal families, and how well, or what areas are strengths in your family, or areas that could be used for improvement. Some of you maybe have already had experience with a parent or a grandparent or a child or some member of your family who's needed nursing care, and what that was like, and how you were recognized as part of, if you were one of the caregivers, how did that relationship go? So it's, thinking about your own families and realizing that, yes, families can be overbearing. They can really be difficult sometimes. And sometimes they're not therapeutic and they're a problem. But more often they're just caring and want the best for their family member. And so, there's rare instances, particularly in the hospital. And keep in mind, when you're taking care of somebody in the hospital versus caring for somebody in their home, the dynamic is completely different. In the hospital, you're kind of in control as the nurse. You're more or less able to direct how things are going to go. And if you have a family member that's really out of control, all you have to do is, call security or something like that, or try to have some type of a therapeutic communication with them to try and calm things down. Versus when you're in a person's home, it's their home, it's their territory, they're in control. Okay, so the tables get turned a little bit, and so that's why it's so important for you as the nurse to have a really strong relationship, therapeutic relationship with this patient and their family in the home, so that, and it has to be trusting, so that they get to lead because it's their environment and their home. I mean, you're the guest in their home. But finding a way and knowing what those relationships are within that family will help you in caring for that person in that setting, in the home setting, as an example. So there are some patients that go home and have no caregivers, and they would only go home with home care services if they're safe, which we'll talk about in detail later. But 9 out of 10 times, patients are not just themselves. They have a caregiver, a family member that's also involved in that care. And so they need to be included in the care. Okay. So the 15-minute interview, the family assessment, the family involvement is all another very important component of community-based nursing is involving that family in the care. And so I think pretty much that's it. And again, with the cultural assessment, that if you don't know what's okay in somebody's culture, it's okay to ask them if in their culture it's acceptable to do whatever it is that you need to talk about. Okay. All right. Questions on any of that? Okay. So now I'm going to bring this up and hopefully it's going to work. And that's going to be tricky, but I'm going to go full screen and share this one. So healthy people. Let's see. This is the activity. Can you guys all see it? So I need to put you into, hold on a minute. So this is where technology gets pretty tricky for me. So bear with me a minute. Okay. I'm going to close that for a second. Oh, wait, here. Oops. Go back here for a second. Okay. Let me put you in groups. Okay. Let's see. Breakout rooms. Tell me, let's see if I can do this. I'm going to create, how many are you? 3, 6, 9, 12, 15, 16, 17, 4. I'm going to do 4, so you won't actually be in your clinical group necessarily for this, but I'm going to create 4 breakout rooms. There'll be 4 of you in each. Is that right? 1, 2, 3, 6, 9, 12, 15, 16, 17. So 4, and then one group will have 5. Okay. And let me see if I can. Okay. So in room 1, I'm going to, so Angela, Neff, who else is in your, no, I can't do it that way because you're only 3 clinical groups. So I'm going to do Angela, Antoinette, Ari, and Bridget, and Caroline will be in one first group, okay? Group 1. Group 2 will be Christine, Dana, Hazel, and Karan. Is that how I say it? Okay. Next group will be Kelly, Kirsten, Nakia, and Ophelia. Oh, there's only 3. How'd that happen? Okay, I'm going to take 1 out of that room. Carol. All right, let me finish this. 1, 2, 3. What's going on? Oh, here we go. Pearl, Sony, Stephanie, and I'm going to take, okay, so let me go back to Caroline and move you to room 4. Okay, so I'm going to open the rooms. You guys are each in a room. You're going to look at the assignment, and then also there's the go to the Healthy People 2020, and on Blackboard I included the brochure and the fact sheet, and if you open them up you'll see the health indicators and you'll see the topics. I gave you each group a topic, and that's on that assignment sheet, and I want you to work for 15 minutes and you're going to come back and talk about what you found out with this. So let me open the rooms. The assignment has the directions. Does that make sense to everybody? Let's give it a try. All right, so you're going to your rooms. All right, you should be. There we go. Okay. And here is the, didn't I have it there? Here we go.
That was awful.
You need to,
Well,
do you see the activity and everything?
We have it pulled up.
The Healthy People
Okay,
20.
and so you're group one, so you're going to report on access to health services? You see that?
Okay.
mhm.
Okay, then I just want to make sure everybody's good. Thank you.
Thank you.
Let me
I was
go
trying to
on.
figure out how to respond back. I saw your chat message, but I'm not very techy.
Okay, all right. Now I need to leave that room. This is terrible. Okay, leave breakout room. Hi, everybody. I'm just checking in. Do you know what you're doing? Do you see the assignment and you pulled up the indicators?
Yes.
You're all good?
Yes.
Excellent. Thank you. All right, now I gotta figure out how to leave this room. You all can do your thing. I'll just leave the room if I can figure it out. There it is.
Activity, adults who are obese.
You guys are good. You're doing okay? Everybody knows what they're doing, right? Just checking in. Sorry to interrupt. Yes?
Maybe.
Maybe. Well, do you see the directions, what you need to do?
Yeah.
Okay. All right. Do the best you can.
Okay.
Okay. Sounds like.
Okay, I see where you're at, Kelly.
Okay. All right.
So
All right, I
how do
see
we
where you're
find-
at.
How do
Yeah.
we find out how we're doing? Or we just have to,
You're going to answer the questions on the activity. Let me pull it up here. Hold on, because if I keep going there, I lose it. You have a topic and you want to report on that with looking at the leading health indicator. Hold on a second.
okay.
Just look at the activity instruction.
Okay.
Can't get to it, unfortunately, the way this thing works. So keep going with what you're doing.
Okay.
Okay. So let me put.
So you guys are doing okay.
Yes.
Excellent. Good job. All right, I'm gonna step out. I just wanted to check in. See how
Okay.
it's going. All right.
Thank you.
Thank you. Now I got to figure out how to get out of here. There it is. Okay. Okay, so group one, go ahead and tell us what your, let me pull this up. Tell us what your indicator is and the health impact and the other questions. So group one.
Okay, did you want me to share my screen or just go ahead and
Sure,
read what
if you wrote it on and you can share it, that'd be great.
Okay, give me just a second to figure this out.
Okay. And I also got an email from Dr. Eck Elliott, so I do have your clinical groups now too, so that's good.
Can everyone see this?
Yes.
Okay. So our group, we were access to health services. The first question, well, that was our indicator, access to health services, and the health impact is preventing disease and disability, detecting and treating illness or other health conditions, increasing quality of life, reducing the likelihood of premature death, and increasing life expectancy. The report on different stages and the determinants affecting this indicator. So for children and adolescents, we just, as far as like determinants of how it, hold on. This is at the mercy of their parents. So obviously if the parents have health insurance, transportation for the child to go to the doctor, parents' finances, work schedule, availability, and like overall general socioeconomic status. And then this is determining if they're reaching their developmental milestones, if they're up to date on their immunizations, and early screenings for obesity and scoliosis. And then for the adults, what affects this is obviously there's socioeconomic status, access to transportation, work and scheduling if they have time to go to the doctor, and their education. And then for adults, we're looking at screenings, monitoring weight, blood pressure, screenings for STDs, cholesterol, and then the big two are like just preventative for heart disease and diabetes, and then your routine checkups for the aging populations, ages 65 and older, for more age, for eye disease and hearing loss. And then on most current data, how are we doing with access to health services? So between 2008 and 2018, the rate of people aged 65 years and younger, health insurance increased from 7% to almost 90%, 89%. So that was a big jump.
You know why?
And Obamacare.
Yeah.
And then between 2007 and 2016, there wasn't much of a change between people with the standard primary care provider. So it kind of stayed in the 76%, 76.34%. And then those aged 25 to 64 years with an advanced degree had the highest rate of health insurance coverage among educational attainment groups, 96%. So that just has to do with showing that individuals with like higher achieved degrees seek healthcare, I guess, have more, well, they have health insurance coverage, my apologies. And persons aged less than 18 years had the highest rate of health insurance coverage between age groups, and that was at 94.8% in 2018.
So the United States is one of the few developed countries where health insurance is tied to your employment. Most countries, people get health insurance as a right of being a citizen of that country. In our country, your health insurance is tied to your employment. So I think that's a huge gap right there. And something, you know, I think they really tried very hard with the ACA, the Affordable Care Act, to change that. But unfortunately, it's still tied into your employer. So if somebody doesn't have a job or they have a low paying job without benefits, that's why they don't have health insurance. So that is an area that certainly needs to be improved, but very good report. Thank you, Ari. Next group was group 2, and yours, go ahead. Group 2. Who's your spokesperson?
I can, I guess.
Okay, thanks, Dana.
So, okay, so R2, we had environmental quality.
Okay.
So R2 indicators were air quality exceeding 100 and children aged 3 to 11 exposed to secondhand smoke. So we've said that the impact would be respiratory issues such as asthma and bronchitis, allergies, and then children being exposed to carcinogens from secondhand smoke at a young age. I guess for the life stages, we were saying children and elderly would be the most vulnerable. And some of the determinants would be where people live. So if they live in like major cities, they would have a lot more air pollution, and worse air quality, lack of green space. And then if they live in older homes, they would have mold, lead paint in the homes. And so if you have pets, you're going to have a lot more allergens, but then also people in lower social economic statuses could have pests such as mice and cockroaches, which would lead to more allergens in the homes as well. So yeah, this will all lead to disparities based just on the populations at risk. So lower people more in poverty or lower socioeconomic statuses, just depending on where they live. If you live in the city, you're gonna have more cockroaches and mice just based on proximity. I think that would be that for there. And then, so between 2005 to 2008 and 2013 to 2016, exposure to secondhand smoke among children aged 3 to 11 decreased 27%. So that exceeded the target. So they're doing pretty good with that. So we're just saying, so the best group for the secondhand smoke would be non-Hispanic Asian children. They had the lowest exposure to secondhand smoke. So then 66.2% among non-Hispanic Black population had more than 3 times the best group rate. 38.1% among the non-Hispanic white population had 89.4% higher than the best group rate, and 25.9% among Hispanic or Latino population was not very significantly different from the non-Hispanic Asian children.
Right. Okay.
And then among the poverty threshold, more than 4.5 times the best group rate. 45.2% among those families with incomes at 100 to 199% of the poverty had more, 3.5 times the best group rate. 30.9% among those families with incomes at 200 to 399% or more than 2.5 times the best group rate, and 22.4% among those families with incomes 400 to 499% of the poverty threshold, or 94.7% higher than the best group rate. And those were all for the secondhand smoke, I think.
Okay.
Yeah. Then the air quality, it just showed that it's been improving since 2006 to 2008.
Okay.
So
what this is showing, what I'm seeing here then is people that are below the poverty threshold have a much higher rate of respiratory illness from secondhand smoke.
yeah.
So that really hones in on where the work needs to be done. Is there any improvement among that population? It doesn't look like it. Is there improvement? Let's see. Well, yeah, there was a decrease. Yeah, there was. But again, this is just children in general. So there is a decrease, but there's still a lot of work to do, it looks like from this information. Is that about right, Dana? Not to put you on the spot, whoever was in your group.
My group could help. But
All right.
yeah.
Okay, thank you. Okay, so group 3. Who wants to report for group 3?
I'm going to share my screen.
Thank you, Kelly.
I'll speak.
And Kirsten will speak. Okay.
Okay, can you see it?
Yep.
Okay.
Okay, what is the indicator and what is the health impact? So, of the nutrition, physical activity, and obesity. So it's adults and children with obesity, adults who meet current federal physical activity guidelines for aerobic physical activity and muscle strength activity. These children and adolescents who are considered obese, and total intake for persons aged 2 years and older. So basically, it leads to body image issues, which could lead to eating disorders, chronic disease such as diabetes, hypertension, cardiovascular disease, and also could lead to depression. Report on the life stages and determinants affecting this indicator. How does this lead to disparity? Genetics and family history, lack of education on nutrition, lack of access to healthy foods. Examples are food deserts, lack of access to technology, and like socioeconomic status, I think, can play a part in that as well.
Is that across the lifespan? I'm sorry.
Oh, yes, I think, yes. Yeah, I mean, children basically have to, most of them have to eat what their parents cook or serve them. So they're at a disadvantage, because at least as an adult or an older, like a teen, you have more of a choice of what you're going to eat. So I think that's where children are a little different in that scenario. But yeah, I think socioeconomic status has something, is for like all across the board, throughout all of the life stages, because it has to do with their access, as to healthcare and to food, certain kinds of foods, to technology. So report on most current data available. How are we doing with this indicator? So we thought that I have some statistics written on my paper, and I'll share them. But on here, we were talking about how calories now are listed on menus if you go out to eat, when they weren't before. When you go to the grocery store, there's labels on products that are pre-made, what's in everything, the calorie count. Yeah, they stopped allowing trans fats in foods. I think so many years ago they did, and they were allowed before, and then they stopped because I think they realized scientifically that it wasn't good for people. Nutrition labels, more gyms are available. People, I noticed gyms popping up everywhere. My Plate, that has to do with technology. People can access that, plan menus, help with their nutrition. Portion control. Technology gives access to knowledge, which absolutely. And then some of the statistics I wrote down of healthy people were between 2013 and 2016. So in those with incomes under poverty threshold, it was 42.1% were obese. 42.9% of individuals for incomes 100 to 199% below poverty threshold were obese. And then adults over 20 born in the US, 40.6% are obese. In basically in comparison to people not born in the US, it seems like people in the US that are born here and live here their whole lives, or have a higher obesity level than people that are born in other countries and then move here. And I'm thinking that might be because they create, those eating habits early on, maybe in another country or a different culture, they have different eating habits. And then, so I think that might have something to do with it. And then groups with private health insurance have the lowest rate of obesity at 37.1% versus public insurance, which is 45.8% of obesity. And then, yeah, so.
So the statistics, is there, how is it comparatively? Are we doing okay on this? We doing better, worse? Is this something that will continue to show up on the healthy people indicators, you think?
I think it'll continue to show up.
You do think it will?
That's my personal opinion.
Yeah, so without seeing the numbers, where are we? Are we better or worse or the same? Were you able to determine that?
I honestly didn't look at the older statistics. I'm sorry.
That's okay, that's true.
But I just think that 42% of people that are obese, I mean, that's almost half of that population. So that's pretty high.
Yeah. Yeah. We got a long way to go with this one.
Yeah.
Absolutely. And the reasons that you list there, are the fact that we do have food deserts and we do have lack of access to technology. And yes, genetics do play a part, but I think that again, the education, so this is definitely an indicator that, when you have obesity, you're going to have chronic disease, and we know what happens with chronic disease. Then your leads to more illness, and increase in healthcare spending, and it just overall is, it's harder to get around. It's just all the things that go along with it. So that was great. I think it's definitely something that we will continue to see on the healthy people indicators. So very good. Thank you. And then finally, we have group 4.
I'll share my screen.
Okay. Aw.
Oh, yeah, that's my dog, Franklin. Mess. All right. So we did clinical preventative services, and the indicator that we focused on was adults with hypertension and blood pressure is under control. So we said health impact would be chronic diseases, stroke, heart attack, heart failure, and chronic kidney disease. And the life stage for this, we said 18 years and older, but mostly in the older population. And social determinants, less resources, no access to health insurance, lack of nutritious foods, rural versus urban areas, so the lack of the green space for exercising, non-compliant of medications due to the side effects, working in high stress occupation, increase in responsibilities due to family dynamics and genetics. And then for the current data, we found 60.8% of population was targeted, and 47.8% of adults age 18 years and older with hypertension have it under control in 2013 to 2016. And then we also found a recent statistics that said 1 in 4 adults with hypertension have their blood pressure under control. So I feel like it's definitely something that's going to keep popping up on the leading health indicator topics.
Okay. Yeah.
So
well, very good. Thank you.
Yeah.
All right. So all in all, was that helpful to just kind of give you an idea of how they look at those indicators and, the different topics and how we measure and what we need to continue to focus on? Again, it's all about health promotion and wellness. So very good. All right, so that's all we're going to do for today. Now, our next class is scheduled for Wednesday, which I may be out of town for a funeral. My beloved auntie died, and so we haven't heard yet. She died yesterday, so her funeral may be Wednesday. I kind of doubt it will, but if it is, what's going to happen is we'll probably, so the class that's scheduled 2 weeks from today is the simulation. But with the simulation, we're not going to actually go into the lab and do the simulation. I have 2 case studies that will open up for you. I think I have them scheduled to open next week, because I don't want you to start working on them yet because you don't have enough information to be able to really do those 2 case studies. So they're scheduled to open, I think, after the class this week. But anyway, so with that being said, if I have to, and I will let you know as soon as I've been waiting to hear from my cousin, as soon as I know whether I'll be here or not on Wednesday, I will let you guys know. But in the event that we do have to move the class, everything will just move by 1 class, and we'll have the 4th class then on the day of simulation. Okay. As far as the case studies that will be in lieu of the simulation, I have them set to open up for you at the end of this week. I think it's after class, maybe after class 3. I'll double check it, but you need enough information to be able to complete those 2 case studies. Okay. They're not graded activities, but they will be very, very helpful. Oh, thank you. They'll be very helpful for you in terms of understanding about mainly home care, as well as discharge planning and care coordination. That's what those 2 case studies are. So as soon as I hear and I know for sure what's going on Wednesday, I will put a message out on Blackboard. But as of this moment, I believe class will continue as scheduled. Like I said, I haven't, there's still nothing from my cousin. So as soon as we know, I'll let you know. And have a wonderful day. Thank you for a great class. You guys are really awesome. And I'll see you either Wednesday or next Monday, okay?
Thank you.
Thank you.
Thank you.
Thank you.
Thank you.